three cases. Probably will not extend to too much. We'll limit to 30-35 minutes. The case 1 is a 62-year-old male, known case of NHL, stage 4, received 6 cycles of chemotherapy like rituximab and bendamustine in January 2022. He also had history of proven pulmonary tuberculosis in July 2022 and took ATT for 6 months. So I have treated him. Basically, I have diagnosed pulmonary tuberculosis. It was we did BAL for him, and it came out to be positive on gene expert. So it's a proven tuberculosis. So he improved with the ATT. Then 5 months later, he had a history of admission with lower respiratory tract infection. So on evaluation CT test, we can probably.
Yeah. So if I start off with you, Samir. So CT, this is someone who's got a history of immunosuppression, comes in with a CT like this. The immunosuppression is with 6 cycles of rituximab and bendamustine, with the rituximab bit being relevant, I think. What's your interpretation of the CT for the audience? So if you can just do a brief interpretation of that CT for us.
You can see some solid nodules, you can see some ground glass nodules. Now, in this case, especially with the history and majorly immunosuppression which is there, the first differential definitely that will come to mind is some sort of an infection. Now, differentials for this infection, of course, one, tuberculosis, because that is one of the most common things, and secondly, the patient already has this history. If we have to think about other things, yes, this could be PCP, although not very classical opacities for pulmonary, Zerovitz pneumonia, but still it could be. Other viral pneumonias, or maybe some other atypical causes of pneumonia, other atypical bacterial causes as well. So there's a huge list which we would point out at this point of time.
Sure. So just go back to the CT for one moment. Sorry. So there are two things that Samir points out, just the other one. Yeah. So one is the previous slide, Lokesh, just the one which is the static image.
Yes.
So there are two things which Samir pointed out there for people who are not used to seeing CTs that regularly. So you've got these nodules there. So you can see all the nodules that Samir has spoken about. These are the nodules on there. And this tree in bud here, which indicates bronchiolitis. So you've got small airways which are stuffed with secretions, which is the bronchiolitis in the tree in bud. And like Samir said, TB is first, but any atypical infection, other viral infections, all of these can result in the tree in bud bronchiolitis that was spoken about here. Yeah.
So to continue, so what next? We did bronchoscopy, lavage, which was negative for TB, and culture was normal flora. He was treated with IV antibiotics, Pertham sulbactam, oxygen support, chest physiotherapy. He responded well and we discharged home. So in a week's time.
Can I just stop for a moment, and I'll come to the ID specialist. So this is someone who has a history of being given rituximab and bendamustine, comes in, has 7 days worth of antibiotics, has a CT which looks quite severely affected. We saw the entire scan scrolling upwards. Would you actually look at his background immune status at this point, or do you think one-off infection, good response to antibiotics, quick recovery, you don't really need to go into the nitty-gritties of the immune status of the individual at this stage?
I would definitely consider the background immunocompressed status, because mind you, this patient has received bendamustine. Bendamustine is one of the powerful immunosuppressants. Just knocks out your T cells. And he's also on rituximab, which knocks out your B cells. So he's on severe both B and T cell immunosuppression. At this point, with this CT scan, number one is tuberculosis and certain other things. If he is from an endemic area, I would think of histoplasmosis too.
Sure.
And I wouldn't, even though this patient's got better with antibiotics, I'm somehow not comfortable in sending him home, because I want a tissue biopsy in this patient. Because this is not a typical bacterial pneumonia for me to get better with cephalosporin sulbactam. There is some story going on inside. Because these are heavily immunosuppressed patients, you can have a superadded bacterial infection, which probably would have given you a sense of getting better. But the underlying thing has to be addressed. Now, you may say that, see boss, I'm done the bronch, but I didn't find anything, I'll send him home. But this is a miliary pattern, where I get the diagnosis with a proper tissue diagnosis. So, in fact, this patient, I would push you to get a tissue, a biopsy, because that is something in my mind. I'm not very much convinced in sending this patient with the transient improvement what he had with this
Yeah.
Antibiotics.
So I think it's an important point. So we have the benefit of hindsight. So we've all seen the case. Lokesh has been kind enough to sort of share the case. And I have to tell him that if I was in a similar situation, I probably wouldn't think twice about sending this patient home either. But if you think about it, the carry home message for all of us, a patient like this, like was pointed out just now, needs a further diagnosis, needs tissue. We need to consider the background immunosuppression. This is unlikely to be a bacterial infection only being the operational word, and hence this needs to be followed up closely, needs more tissue, needs a diagnosis. Yes, go on, Lokesh.
So in week's time, he again readmitted in emergency. This time he didn't give us time. He just got intubated in emergency. He was then he was connected to ventilator support. He was in septic shock, requiring vasopressor support. So thinking about background recurrent admissions and also history of immunosuppression, we started on high and broad spectrum antibiotic, and also to cover atypicals, we started on meropenem and azithromycin. Then this is a CT scan. CT scan,
So I think very quickly, we'll not dwell on this. So you can see there's much more of tree in bud. There's a little bit of fibrosis, but most importantly, there's a left lower lobe consolidation that's not now appeared, which was not there on the previous CT. So before we go forward, this choice of antibiotic, the choice of meropenem and azithromycin, in our ICU also the predominant organisms are all gram negative. Do you think you would actually have given a gram positive cover here, or do you think that's not really something that either one of you? So a quick response.
The commonest, now that this patient went home and came back, now it is two things. Either it is, and the patient is sick in the septic shock. So in a septic shock patient, my early antibiotic choices should be correct, because if there is a delay in antibiotic treatment, the mortality goes up. So I'm going to cover broad. So the simple is, my understanding is it the progression of the same etiology, which I feel is the likely cause, or number two, he has a new bacterial infection, which is very well possible in this patient. So the commonest pneumonia bugs are, other than your pneumococcus, in an immunocompromised patient, I'm going to think of gram-negative Pseudomonas and MRSA. And this patient is sick.
Yeah.
Till I know what it is, I'm going to give a MRSA coverage also along with this treatment, till I know what is happening.
Yeah, so I agree with Dr. Vishnu Rao. I think in someone so sick, needing ventilation, needing iron drops, you would definitely give this patient a gram-positive cover. What do you think about giving an antifungal cover empirically in someone who's sick, who's hemodynamically unstable? Dr. Vishnu Rao.
Yes, sir. Sir, the antifungal, in the sense, I'm going to decide what fungus it is. First of all, I need to have a clear understanding. The fungus that comes in the lung, it either has to be Aspergillus or Mucor. Both of these are the likely organisms, if at all. But my points are generally, if it's an Aspergillus pneumonia or a fungal pneumonia, it will not go so rampant. Aspergillus Mucor, it's a local destructive process, and then secondary bacterial infection, then bad. But
fair point.
This causing this one is still
so gram positive and gram negative cover, atypical cover, but no antifungal cover empirically. We haven't done a BAL. I saw the next slide, so you've done a BAL anyway. So I think anything you wanted to say, Samir?
Yeah. Another thing is, I think the opacities, the infiltrates are not very classical of a fungal infection, what we see. So possibly we can just skip it. And as Dr. Vishnu also pointed out, the course is so rampant.
I think the question here is there also a fungal infection, as opposed to is there only a fungal infection? I think that's probably what we are looking at. But yeah, go on, Lokesh.
So I think I missed our microbiology. Somehow I was thinking why one seat was vacant. Can you please come up, ma'am? Thank you.
Oh, I'm so sorry, sir. I also thought that our microbiologist colleague is missing. Dr. Sireesha, please come, have a seat. Sorry about this.
So we did bronchoscopy for this patient. We have sent biofire because we have all indication to send biofire. He is immunocompromised, recurrent infections, on ventilator. So we have sent biofire, which has shown Haemophilus influenza, which is detected in biofire with no other drug-resistant genes and no other viruses. Ball culture was sent. So this is a scenario. Then
so just go back and we'll get our microbiologist colleague into the discussion straight away. Yeah. What do you think about this? So patient come in very sick, inotrop requirement, unstable, the CT looks bad, just a Haemophilus influenza and biofire and nothing else in a patient with the background immunosuppression. What do you think is going on? Do we just take it as being a Haemophilus pneumonia and sort of treat it accordingly? Or do you think there's more to it which we have not detected till now?
This patient Hello. Can you-
Yeah, we can hear you.
This patient had a previous hospitalization, so definitely there is something we were expecting that could be a gram-negative with drug-resistant bacteria. Another thing is because he was on immunosuppression and all, this patient already admitted and got discharged. So we think that this could have been a community-acquired pneumonia superadded to the previous. And actually I was thinking of gram-positive coverage. How frequent do you think a gram-positive coverage is needed for a patient who comes out with this kind of presentations? Because we hardly see any MRSAs or MSSAs presenting this kind of presentations. So are you justified in giving a gram-positive coverage is my question.
Yes, ma'am. I mean, empirically, now that I have an answer, but when that patient has come to my community, come in the hospital, in the ICU, we need to, because he's in septic shock, delay in antibiotic therapy will increase the mortality without covering. So I am going to cover everything possible. Then once the culture is back, I am going to de-escalate. So
Correct.
this is the strategy we're going to follow. Now, the point is what I am not okay with is this patient requires, I have done a BAL, not only BioFire, I am going to send for gene expert, I am going to send for AFB smear, AFB culture, I am going to send for fungal smear culture, expert, nocardia. Mind you, this is an immunocompromised host.
Yes.
In immunocompromised hosts, surprises are not uncommon.
Yes.
When you go in, I'm going to get all this, and because
Yeah.
I'm not still convinced that this is only Hitch influenza. There is more to the story which we need to identify.
Yeah, and I'm sure
No,
everything was
this-
sent,
Yeah,
wasn't
but this
it?
patient, I think he had
We did everything.
negative.
We did
Yeah,
everything,
I'm
but
sure
I
it
didn't
was
mention.
negative.
I have sent
Nocardia,
everything. Nocardia, AFB, Gramsci. Gene expert was done twice. Even just before admission, we had before admission we had done gene expert again. It was negative. So gene expert was not sent again. In a week's time, we didn't do. Otherwise, all mentioned possibilities we have done.
Yeah,
Yeah.
he had a good sputum specimen which was having a predominant
Yeah.
neutrophilic reaction, and I think, if not wrong, there was culture also was positive, I think, but I'm not sure. Not
Okay.
Let's move forward. We've got more to the story. So, yeah, Lokesh.
So antibiotics were de-escalated to levofloxacin. Then his clinical condition slowly improved and vasopressin weaned off on day 5. And GCS improved a lot. Then in view of recurrent admissions due to infections, immunoglobulin profile was sent, which was very low, which is 148. The normal range 700 to 1500, which suggests of hypogammaglobulinemia.
So we'll stop again and maybe pick your brains, Dr. Vishnu Rao. So this is someone who's had rituximab. The last course was about 5 months ago. We know the rituximab knocks off the B cells completely. So A, do you think this low IgG is secondary to just the rituximab which was administered 5 months ago? Or do you think that this patient might have had a low IgG to start with, low immunoglobulins to start with, and has been worsened by the rituximab? And is it important to find that out?
I personally think this is rituximab inducer because there is another condition called as common variable immunodeficiency, which gets in a younger age group. If this patient had a CVID from many days, he would have landed in bronchiectasis by this time the moment he landed. So I think in a patient with appropriate setting who already been given immunosuppression, which are known to cause rituximab knocks off my CD4 in 6 months. So this is all rituximab related. Now the problem I have is I don't de-escalate to levofloxacin. I have a problem in giving levofloxacin in my Indian patients in immunosuppression where I feel that there is some background issue is going on. I wouldn't de-escalate to levofloxacin. Probably I would have been very comfortable in giving to amoxicillin or ceftriaxone because giving levofloxacin in a background pretest probability of a coexisting TB is going to increase my TB resistance to. That is the reason for isolated levofloxacin resistance in pre-XDRs in our country. So this is something I have a problem.
It's ruled out twice. Gene expert was negative twice in a week's time. So that was the reason we de-escalated.
But I think,
as a pulmonologist, we all have concern for tuberculosis. I made sure there is no tuberculosis. Then that's the reason we started de-escalated. And also, I could not go back to amoxicillin because this patient was ventilated. So I want to cover some other bugs. It is broad spectrum.
Sure. So I think, broadly the points that Dr. Vishnu Rao made are very important carry-home messages. First, the fact that we give levofloxacin as a single agent, this is an exception for the reasons Lokesh spoke about, but to give levofloxacin as a single agent in our country is probably something that we want to avoid as far as possible. I think that's important. And the other point is about rituximab-induced low immunoglobulin levels. The fact that a lot of these patients have some form of low-grade combined variable immunodeficiency and over a period of time develop bronchiectasis where you have bugs colonizing, so the pseudomonas, the Klebsiella colonizing, and hence whenever they get a pneumonia, the condition becomes from bad to worse. So those are 2 points I think which is worth remembering. Let's move on.
So we have consulted our medical oncologist, had a discussion. We thought we would give IV supplements. We gave him IVIG 400 mg per kg per day IV, and for 5 days. So on day 10 of hospital, patient had a new onset of fever, worsening clinical condition, requiring high FiO2 again to ventilator support, which we typically see in this set of patients. So we had to tracheostomize him on day 11. So then ball culture was sent, which has shown MDR clefture at this time. The colony count was more than 10 to the power of 5. Then antibiotics were escalated to polymyxin and digicycline. Polymyxin was intermediate, digicycline was sensitive in this patient. So we thought we would give combination therapy in this patient. So then that is the story.
Sure. So I think I would agree with this, Lokesh. Maybe we need to go on. So polymyxin TJ I think would be a reasonable combination, at least in my ICU. Some people would argue that we could have gone for a polymyxin saving strategy. So something like a Astionam and Zavicefta combination. I'm using a trade name, I'm sorry, but that's convenient. So maybe a quick comment from Dr. Vishnu yourself about colistin saving strategy, using a combination where you have an Astionam along with sparing agent. So your thoughts about combination? A quick comment.
Carbapenem resistant Enterobacteriaceae, whether it is E. coli, Klebsiella,
Sure.
if the in vitro susceptible to ceftazidime avibactam or combination is sensitive, this is preferred over polymyxin based combination therapy. Number one, although I don't have an RCT to quote, there are a lot of observational studies, retrospective studies are clearly pointing to, because beta lactams are the better drugs. We are using polymyxin till recently because we don't have any other drug.
Sure.
So those are better drugs than this. Now, when I would use polymyxin based combination is for my Acinetobacter, where your ceftazidime avibactam Astionam doesn't work. Number two, carbapenem resistant Pseudomonas, where 50% will be resistant to ceftazidime avibactam plus Astionam. So these two bugs are the place where I am going to use a colistin or a poly-B based combination therapy. But for others, E. coli, Klebs, as long as Casavi Astionam is sensitive, this would be a preferred drug because of the less toxicity and better outcomes.
Yeah. So that's a learning point, and I think that's the last slide for the first case, isn't it? Is there any more?
I think so. We thought of asking. We have done around 100 biopsies in hospital. First 100, I think. Yesterday, when we were presenting this case, we had the data. So I thought.
So please, Dr. Sireesha,
Thought
comment about biofires.
Sireesha, take the question. Slide actually I forgot. Other system. So I'm sorry.
So we have done nearly 100 biofires in our setup, and we have found that nearly, I think, 60%, unfortunate to say that, like 60% of the isolates which are gram-negative are having multi-drug resistant genes in them. The problem is bacteria always have genes which are drug resistant. They start expressing when we start misusing the antibiotics. So, and currently in our ICUs, the only option which we are left with is polymyxin, tigecycline and ceftazidime avibactam with azithromycin combination. And in order to select a drug, like as Doctor was telling, like ceftazidime avibactam with azithromycin combination, you can only give provided you know what are the carbohydrate genes which are present in the different organisms. First, you should know the organism, what it is, what type of gene it is present, and then you have to know the MIC values, and you have to do a synergistic testing in the lab. Then only you can report whether it is sensitive or not. But with a multi-drug resistant Klebsiella present there, without doing the testing, we cannot really go and give ceftazidime avibactam. So you should have a proper testing in the lab with what type of organism, what genes are present, and synergistic testing with MIC values. All four put together, you have to decide like what is the choice of antibiotic for your drug-resistant bacteria.
Yeah, so very valid point. So we have actually presented, I'll take another minute, Lokesh, before we move on. One of my colleagues presented at the ERS our experience with about 257 biofires over a period of 2.5 years. And very similar experience as yours, but I think there's a couple of things that need to be said about biofires, which is important for interpretation. So first, you will get a lot of mixed organisms. So you will get the Acinetobacter, the Klebsiella, maybe the staph all together, and the number of gene copies of the organism is important. So we found anything at 10 to the power of 6 or more gene copies normally grows things on cultures are relevant. So if you get a mix, some of them would be 10 to the power of 4, some 10 to the power of 5. It's the 6 to 7 which are important and relevant, and hence the sensitivity profile that you see on genetic susceptibility is also relevant for those bugs rather than the ones which come with very, very low colony count. I didn't know whether you had a comment, Dr. Sireesha, about that.
We had a mixed infections, and I think there are some reports where we have reported 6 organisms with greater than 10 to the power of 6. But do you really need to go ahead and treat all these organisms is a query. This depends on, again, the colonization. It's very difficult for a consultant to decide whether it is a colonization or should I go ahead and treat it and all like. So it is always been a clinical call which needs to be taken with a radiological picture, clinical presentation and the laboratory diagnosis. Put together you have to decide it. Because a lot of dead bacilli and bacteria also will be shown in the biofire as positives. And mixed infections, viral and bacterial, put together also we have a lot of infections.
If I may add one point, I want to make it here. One of the most important things as we use more and more these techniques, we land in treating colonizers. Especially when you go for these pneumonia panels and all, try to go for the deeper sample. The deeper you go, the better is the sample and the likelihood of organism representing the true infection also goes up. The more sputums you ask, sputums comes from your lungs and throat, and then so all the colonizers gets picked up. So the best thing is a proper quality sample gives us the likely diagnosis. Number one. Number two, whether you take respiratory secretions or urine, you can have 100 organisms sitting there. Ultimately, treating is the clinical decision. I don't care how many colony count. I don't care whether it's 10 power 100 also. I don't care. If the patient is ventilated, unless I have fever, increased secretions, patch, increasing counts, and then on top of it I am going to interpret my ET secretions, whether it is panel or cultures, because lot of time we end up, in fact 20% of my referrals are normal ET secretions which are just colonizers. This patient doesn't have fever, no patch, no oxygen requirement, don't go up, we don't treat them. I think it's the discretion of the clinician to decide on how much treatment.
Sure. And one last message from you, Samir, about vaccination in this population.
So again, I think a lot of people, Dr. Kavya and Dr. Deepika also pointed out that vaccinations are something which is important because they do see a lot of infections. In fact, she showed that I think about 48% of them who receive rituximab get infection in the first half of this. So vaccinations are important, although we just have to keep in mind that what sort of vaccinations are we giving, whether it's a live attenuated or an inactivated vaccine, and what should be the timing. Now, most of these people, I think, especially in this particular criteria, when you are giving rituximab, you must have multiple cycles. So either 4 weeks before giving the next cycle of rituximab, when the patient is quite stable, not really immunocompromised, you've done all IgG levels and all, and if you have to give any live attenuated vaccine, that would be the best time. But ultimately, all data shows that efficacy of about 73% from pneumococcal vaccine, up to 97% with shingles vaccine. So definitely an important part.
Sure. Thanks. We'll move forward.
Yeah.
Yes,
So
Lokesh.
next case, she's a 17-year-old female with history of cough and expectoration, low-grade fever, and breathlessness. She's a diabetic, past history of hysterectomy, and she also had DNS. She had a DNS repair. And when she presented, she was requiring 2 liters of oxygen support. So this is X-ray.
Yeah. So Samir, X-ray. Very interesting X-ray. So tell us about this X-ray.
Yes. So as everyone can see, there is, grossly you can see there are 2 big cavities. You can call it cyst also, but mostly it's thick wall. So these are 2 cavity lesions. One is in the right parahilar region, close to the cardiac shadow, and second is the left lower location. Now again, the differentials based on this could be any cavitating lesions such as a necrotizing pneumonia, but again an odd place for that to happen. Tuberculosis, one of the most common things. Lung abscess because of any other reason, or it could be some other infection such as, or other causes such as malignancy, less likely, but yes, vaginas or something like that.
Sure. And the CT now?
Yes, so the CT scan when we see for the same patient, this is in fact showing large thick walled cavities bilaterally. These are fluid filled also, so again one could really think about either lung abscesses or these could be vaginous disease or something of that sort. Necrotizing pneumonia is another possibility in these cases.
So the more you see, the chances that this is some form of vasculitis causing cavitation probably goes up, isn't it? From the X-ray to the CT, your chances, your possibility goes up significantly. Shall we move on, Lokesh?
Yeah. So, but with the fluid level, it's so
Yeah.
common. Usually we see cavitations. When you think of cavitation, the fluid levels, I would always want to rule out infection before we think of any other vasculitis. The patient is presenting to me with the symptoms of fever and cough.
So absolutely, yeah. So absolutely right, Lokesh. I think we are talking more about what the background condition is and whether there is a background condition on top of which you've got a right lower lobe lung abscess. So the fact that there's an infection, I think, is undoubted. It's more about what is the background.
Labs, WBC counts as 27,000, hemoglobin is 6.8, CRP is 360. Rest of the labs are fine. So this is so I approached with as I was thinking infection. My first differential was infection, road infection. With tuberculosis could be other infection possible. She was diabetic also, road fungal infections. So I did transbronchial lung biopsy, BAL, and the biopsy was done on the wall cavity. So here's the image. I think my pathologist madam is also sitting in the panel if I'm not wrong. Yeah, she is Anupama. So we can actually appreciate. Can you appreciate from there? Yeah. Can I have a comment from you?
That looks like an acute inflammatory infiltrate with admixed with necrosis. There are no other cells which are seen were seen on the biopsy and also the material which was submitted.
If I'm not wrong, all these are neutrophils.
Yes, all are
So it is suggestive of acute inflammation.
polysegmented nuclei.
Okay, thank you. So there is nothing to suggest of.
Suggesting we should have done a biopsy in the previous case.
Yes.
I'll ask you why you did a biopsy in this case.
Because I wanted to complete the workup. I don't want to repeat procedure for my patient.
Right.
So when the lesions are obvious. So
And I
obviously.
have other differentials. I think these are multiple cavitary lesions in a diabetic who comes with this. I have few things in my mind. Number one, melioid infections, I'm telling.
Yes.
Number two, invasive fungus.
Yes.
Pulmonary mucus are, we are
Yes.
seeing more and more pulmonary mucus. Although it doesn't look like a typical reverse halocyte, pulmonary mucus, aspergillus, certain pheohyphomycosis and non-aspergillus hylohyphomycosis. These are, along with the Wegener's, these are the differentials in my mind. So I would push for a biopsy, especially because fungus is high on my cards.
Yes, yeah, like you said, when you combine BAL with TBLP, the yield will go on, even in infections.
The only thing which I think, so I agree with you, Dr. Vishnu Rao, but the only thing which goes against an invasive fungal infection is the fact that this patient at the moment at least is not very sick. So you've got a reasonably okay patient, 2 liters of oxygen requirement, hemodynamically stable. So it would be there in my differentials, but probably slightly further back rather than at the front. But I agree, it could be one of the...
So let me tell you the infective workup. This is a negative for AFB, cabbage, budding yeast. Culture normal flora, gene expert not detected, and the stains for nocardia and other things were negative. And biopsy was negative for malignancy, suggestive of acute inflammatory pathology. And she was kept on IV antibiotic. There was no response for 1 week. Then what next? So that was a thing I was in my mind. Once we reload infection and malignancy, obviously we think of vasculitis workup. The CNK is positive and PR3 antibody was 65. The final diagnosis came out with granulomatous polyangiitis. She improved the steroids.
So if I can come to Dr. Deepika. Dr. Deepika had diagnosis of GPA, and I still feel that there was an infection which brought the patient in, and then the background condition came to be GPA. How would you go forward in treating this patient? We've talked about steroid, but how would you sort of do maintenance treatment? What are the choices? If you can give us a brief summary of managing this case, please.
Thank you, sir. So, I would like to know the involvement, if it is a case of GPA. Till now, the workup was done only for the lung involvement. I would also look into the renal aspect. If it is a case of GPA with such a large cavities in the lung in an elderly female, definitely renal involvement has to be looked
Sure.
at. She has serum creatinine borderline. The leukocytosis and thrombocytosis in this case could also be part of a GPA. Apart from infections.
Sure.
And so the GPA can be like, it can have the manifestations, skin involvement, renal, upper respiratory tract involvement and lower respiratory tract
Sure.
involvement. So the triad is upper respiratory, lower respiratory and renal. And the history of DNS repair, whether she had a recurrent epistaxis, whether she had recurrent sinusitis in the past, that was one thing which can give us a clue towards GPA based
Sure.
on the history of surgery. And treatment is always depending on the organ involvement. Not knowing about the renal, considering only as a lung-limited GPA with the large cavities, if we can treat with 1 mg per kg steroid if the patient is not very severe. We don't need pulse steroids, as Dr. Kavya has suggested. A low-dose glucocorticoid itself is enough because the patient is stable. I would treat with 1 mg per kg steroid and an immunosuppressant sparing agent. Cyclophosphamide or mycophenolate are the induction agents that can be tried. And nowadays, the recent trials have shown that rituximab is also an upfront induction therapy apart from cyclophosphamide.
So suppose,
we can try any of these.
So suppose this patient had pulmorenal involvement. You spoke about just pulmonary involvement. How would the treatment change?
The treatment is going to be an upfront cyclophosphamide. Endoxil is the recommended choice when there is a ANCA vasculitis related nephritis, renal involvement. The large data is available with and cyclophosphamide. So we would initiate her on cyclophosphamide.
And I think the important message here is the steroid is first line if there's lung involvement. If there's renal pulmonary involvement, your first line automatically becomes no?
So the steroid will always be the first line for all these because the immunosuppressant that we are giving is all of them are slow acting. They take time to act. In the meantime, we need steroids for the suppression of inflammation that has been happening. So steroids are taken as the first line choice, and these are immunosuppressants are the steroid sparing agents. We take over the action of steroid, and they continue to maintain the suppression of autoimmunity.
Sure. So my point more was the duration of the steroids.
Yes.
Dr. Deepika, so renal involvement, less steroids, shorter duration of time, just pulmonary involvement, longer duration of steroids. Is that a fair thing to say?
Steroids are given either as a pulse steroids or as 1 mg per kg or 0.5 mg per kg steroid, depending on the organ involvement and the severity of the organ that is involved. And the duration of steroid, we will taper them over a period of 2 to 3 months to very low dose like 5 mg, and then it comes down to 0, and we will maintain them on if it is the patient has chosen cyclophosphamide. The choice of immunosuppressant is always by discussing with the patient. So considering the cost constraints and other organ involvement and the patient preference, the age of the patient, all these we have to consider. So if we are giving cyclophosphamide, it is given as a once in 3 weeks for the first 3 weeks. Once in 2 weeks for the first 3 doses, and then once in 3 weeks for the next 4 doses. That is the induction phase with cyclophosphamide, followed by maintenance with azathioprine. Or we can use mycophenolate mofetil for both for induction and maintenance, that is continued for 2 years. Rituximab can be used as an induction agent once in 6 months, 2 doses, that we need to continue for 2 years, and then we can maintain them on rituximab or azathioprine. The risk of infections with rituximab versus azathioprine, there was a large trial on ritazaram, it's called ritazaram trial, which compared rituximab with azathioprine as maintenance therapy with ANCA vasculitis, which says that rituximab is superior in maintaining remission, and then the risk of infections are not high with rituximab maintenance compared to azathioprine.
Sure. So we have increasingly started using rituximab. I don't know whether you have a comment to add or not, Sameer. Anything that you want to add to the choice of agent?
There's a lot of tuberculosis, secondary TB infections, and it's almost like over the last 3 years, we found approximately 60% of patients who received rituximab had a secondary tuberculosis.
Sure.
So that is just one thing which we noticed. Of course, we have to analyze the data also.
Yeah. I can't help but ask Dr. Talwar for a quick comment on this. Deepak.
60% is like you don't have to use it at all.
Absolutely.
We have been using for last 5 years and not more than 10%. Not more than 10%.
Yeah, I think maybe the patients who were referred to us after taking rituximab had this.
Recurrent infections are more common, respiratory tract infection. They can get this Klebsiella and the biofires will show all those kind of stupid things there. But not tuberculosis to that range. Otherwise, I think rituximab will be thrown out.
No, that's true. The only thing was because whatever patients were referred to us who had received rituximab, maybe it was a referral bias at that point of time.
Yeah.
So that was the
Yeah, that's probably right. But I think the risk of infection is there with all the agents that we have discussed.
So let me show you this.
Yes, absolutely.
So I got misled by this. What she told me is she had a DNS. Before that she had a nice nose. Then after surgery, it became like this. If you think of retrospectively, then it looked like classical case. Saddle nose deformity, all these things. But what she actually told is she had surgery. Post surgery, she had this nose deformity.
But a DNS correction looking like this probably would be a very botched up surgery, isn't it? Yes.
Yeah, obviously. So that's the thing. So let me, these are follow-up X-ray, which is beautifully cleared. Let me finish off third case quickly. So she is a 50-year-old female presented with history of cough and breathlessness since January, and she was symptomatically better with local treatment for 3 months. Then she presented with recurrence of cough and SOB class 4. No PND, but no PND and orthopnea. She also had anorexia, weight loss 2 kg in 1 month. History of GERD and denies any other history of CTD. There is no proximal weakness. A family history of CA breast to her mother. So on examination, the skin was normal, breasts are soft, and respiratory system examination, bilateral velcro crackles, and bibasal right more than left. Musculoskeletal, there is no active arthritis. Muscle power 4+ in all groups. This is a CT scan.
So Samir, CT scan. Tell us some differentials. I mean, we've discussed in lines of a CTD, but tell us what the differentials might be here.
So again, the differentials over here, if I see these are bilateral opacities with some form of bronchiectasis also within, and these look like, I mean, my differentials over here could be some atypical infection again, since we are on that topic also. Plus, a lot of times we see this pattern as organizing pneumonia, although it's not a very classical organizing pneumonia pattern, but still possibilities are very much there. Tuberculosis is very unlikely both for the sense of location as well as bilateral distribution. So some form of an infection versus some interstitial lung disease process or an organizing pneumonia pattern would be the major differentials in this case.
Yes. So agreed, Samir. There's also a lot of interlobular, intralobular fissure thickening, isn't it? There's a lot of thickening around the fissures.
Absolutely.
So our CTD right up at the top, but along with that, I think diseases like sarcoid probably could give you a similar pattern. The only problem with the diagnosis of sarcoid, it's more of lower lobar involvement rather than upper lobar involvement, which sort of makes it slightly more unlikely, and infective causes and post-infectious could be another cause.
Yeah, so my first differential is, in this case, I was thinking about ILD, chronically progressive dyspnea and cough. So it was looking like ILD, but there's some amount of organizing pneumonia kind of pattern in the lower lobes as well. It is not the classical ILD what we see. But looking at this, yes, and then we asked for the lab investigations.
Yeah, so we need Dr. Deepika, your help. I always find this puzzling. So tell us what your thought process is about the various autoimmune markers we have on that slide.
So the ANA-IF weak positive cytoplasmic speckle. Weak positive is like 1+ or 2+, they label it as weak positive, or even, if it is 1+ or lesser than that, they label it as weak positive. And if it is a nuclear pattern, we mentioned, but here it is only cytoplasmic speckle. That means this patient is having antibodies against cytoplasmic antigens, which is more likely to be seen in either Sjogren's or myositis associated IL, interstitial lung disease. The cytoplasmic pattern will be positive. And coming to the ANA profile, PMSCL 1+, Rho 52 1+, without the clinical features of PMSCL points towards scleroderma, Rho 52 is very non-specific, Rho 60 is towards Sjogren's. So PMSCL 1+, without any clinical features of skin thickening or arthritis or Raynaud's, I would not give any importance to that. But having said a patient with interstitial lung disease with some antibody positivity with no other cause identified, we can label her as interstitial pneumonia with some autoimmune features.
Okay. What other questions do you have on there? We need to finish. So
the cytoplasmic pattern with no other clues to consider her as connective tissue disease, we can go ahead and do a myositis profile in this patient.
Sure.
So if I think the myositis profile was...
There was a myositis profile in the previous slide at the bottom.
Myositis profile, sorry, I could not see.
Yeah.
So the myositis profile was done and it was showing PL7 2 plus PMSCL 1 plus rho 52 borderline. So it is 2 plus PL7. So the myositis profile, there are two types of antibodies, myositis specific antibodies and myositis associated antibodies. So specific in terms, they don't have any CTD features. They have that category comes under idiopathic inflammatory myositis, where it can be dermatomyositis, it can be cancer-associated myositis, it can be necrotizing myositis, it can be antisynthetase syndrome. These are myositis-specific antibodies.
Sure.
Myositis-associated antibodies, it means that they have some overlapping connective tissue disorder features, and with that, like PMSCL, this rho 52, all these comes under myositis associated antibodies. They can have an overlap features with connective tissue disorders. This patient with PL7, it comes under myositis specific antibody, which is towards antisynthetase syndrome, but there is no history of any arthritis or mechanic Sands, Raynaud's, and no evidence of myositis in the clinical history, but interstitial lung disease. It could still be a possibly ILD secondary to myositis or an autoimmune, because there is no, she doesn't even fit into the classical myositis. She doesn't have any skin rash to say that it is dermatomyositis. They usually have rashes around the eyes, at least transient rash in the past,
Sure.
or some papular rash over the bony prominences like elbows or over the knuckles called Gotter's sign.
Yeah.
If any of these are absent, there is no cutaneous involvement, we call them as idiopathic myositis, but not dermatomyositis. They don't
Sure.
fit into dermatomyositis. And the myositis spectrum is evolving rapidly. The terminology has been changing, the criteria have been changing rapidly over the last 5 years. A lot of research has been happening. With the invent of myositis anti-profile, the antibodies, they are helpful not only for the etiology but also prognostication.
Sure.
Some antibodies like NXP2 antibodies, TIF1 gamma, they give a clue towards carcinoma association. So what we have learned before the invent of myositis profile is, any patient who is being diagnosed with dermatomyositis, we should screen for carcinoma at the diagnosis, and also every year for the next 3 years, because the risk of carcinoma is high. Coexisting carcinoma can be there for the first 3 years of diagnosis of dermatomyositis. Now with the advent of myositis profile and the cancer-associated antibodies, it is upfront, and we can diagnose it or we can suspect that this patient is likely to have carcinoma, and we can work up for the same upfront.
Yeah. Great messages, Dr. Deepika. You also said that the PL7 being positive indicates that the ILD that we saw on the CT a little while ago was most likely under the umbrella of this myositis overlap with CTD, isn't it? Yeah, so that's another important point to remember. I think you've put up important messages on that slide. I think we need to probably finish for lunch. So concluding remarks from you.
She didn't have any clinical symptoms of myositis and problem with muscle weakness. But as a workup, when we actually did rule out malignancy in the case of myositis, there was a lot of inflammation in thigh muscles. So that we thought probably subclinical myositis was there. So that's it. I think we're done.
Yeah, great case.
Thank you very much.
So thank you everyone.
I request all of you to meet after lunch quickly, because we have Dr. Rajadhar's flight at 5 o'clock. He has to leave by 3 o'clock. So don't miss his talk. So just be here in half an hour. We'll start by 2:45 sharp. Thank you.
Thank you everyone.